All right. So welcome everyone to the NETFA Online Peer Exchange. So NETFA, as you know, is the National Education Toolkit for Female Genital Mutilation, Cutting, Circumcision Awareness. And my name is Rani Pramesti. I'm the Senior Project Officer for NETFA. I've been in touch with many of you over the past, nearly a year now. My pronouns are she and they. And I would also like to begin by acknowledging the country that I'm zooming in from. So I'd like to pay my respects to Kulin country and pay particular respect to the elders past and present, including the young elders on Kulin country. I'd encourage you, if you know the names of the Aboriginal countries that all of you are joining on, please put them in the chat as well as a way to acknowledge the countries that you are all on. So a few housekeeping things. Hopefully most of you are familiar with this. Please be present with your video on, ideally, unless if this is not possible due to access requirements or internet issues. Please keep your phone turned off during the entire session, and please don't multitask so that we can all be present here today together. Keep your mic off if you're not speaking. And then you can also use reactions and the chat to ask questions and engage with the group. So these are some of the reaction buttons: the clapping hands, the thumbs up, the love heart, etc. You can also use the raise hand function in the reactions if you'd like to ask a question, and that will mean that you pop up front and center for me on my screen. And yeah, so we can direct our attention to you. We also have an interpreter today for an Indonesian participant. So in a second, I'm going to stop sharing screen so that we can all do this together. Basically, if you're not familiar with the interpretation function on Zoom, I'll get everyone to click on the bottom bar where it says interpretation, and there's a globe button. And then it will pop up with these options of listen in, original audio, English or Bahasa Indonesia. And I'd like everyone to join on the English channel, except for Ibu Nika, who requires the Bahasa Indonesia channel. So I'm going to stop sharing screen so that we can all do that now. And please let me know if you have any questions. And can I get either a physical thumbs up or virtual one if that's all done for all of you? Thank you for the thumbs up. Great. Any issues with that, anyone? Or are we all good? No. Okay, beautiful. Wonderful. So I'll keep sharing screen now. Great. So, okay, that brings us to the purpose of today's event. Many of you would have received a short survey from me a few months ago asking the NETFA network, what do you want the focus of this first 2022 NETFA Online Peer Exchange to be? And here were the top responses. So firstly, those of you who responded said that you wanted to meet and get to know your colleagues who are working on FGMC in Australia. You wanted to get an update on what your colleagues are doing. You wanted to find out about the challenges that people are facing in their work on FGMC, and you wanted to find out about best practice approaches both in Australia and internationally. So that's what we are all here to do today, and we've allocated time across all 4 activities. I think it's also important to say what today is not. So this is a learning space. That's why we've called it a peer exchange. It's not a therapeutic space. So this is not a space where to share about, potentially traumatic experiences that you may have had about FGMC. That's not what this space is for. So please be mindful of this when and if you do decide to share. On that note, we are going to ask all of you to practice content warnings. So for people who are not familiar with what content warnings are, this is one definition, which is content warnings are verbal or written notices that precede potentially sensitive content. And so these notices flag the contents of the material that follows, so readers, listeners, or viewers can prepare themselves to adequately engage, or if necessary, disengage for their own well-being. This is from the Massachusetts Institute for Inclusive Learning. So in this context today, what we will ask for from all of you is, please don't share any graphic content, whether that's visual, and I've made sure to brief the speakers today to not share any graphic visual content, but this also includes graphic stories. Please don't do that. If you have experienced FGMC, please know that you do not have to share your personal experiences ever. I won't ever ask you to do that. You will not be asked to do that. But if you do choose to share your experiences, please don't share graphic details and say a content warning. So down the bottom here with that final sentence around, you can say something like, I would like to share about my experiences of FGMC. And then please pause so that if there are people who would like to tap out for that part of the presentation or that part of the discussion, they have the option to do that. And then myself and my colleague Maria from MCWH will, from Multicultural Centre for Women's Health, can let you know when it's all right to come back in. Okay. I'm gonna touch on just a few strategies that might be helpful if you do end up feeling a bit triggered by anything that we discussed today. Hopefully that won't happen, but just in case, here are some simple regrounding exercises that we've been practicing in the NETFA leadership program. So for example, there's this simple breathing exercise where you count your breath in. So it might be something like 1, 2, 3 in, and then exhale for longer. So exhale for 6. So that's a simple one that you can do to help to regulate your body's reactions to any of the content today. You may also want to look around the room and name 5 things that you see, to help you come back to the present. And then finally, you are able to leave the session if you need to, especially if it's for your own well-being. If you can, please let myself or Maria, again from Multicultural Centre for Women's Health. Maria, can you just give a quick wave? So there you go. Please let us know why you're leaving so that we can check in on you afterwards if you would like us to do that. And finally, if you do have any access requirements, please feel free to let us know after I finish with this slide or in the chat. So I often get asked, what do you mean by access requirements? So this can be anything that you need to be able to be present and to participate today. So for example, some people may need a break every hour, which we will be doing, also for the interpreter's sake. Some people may need to keep your cameras off every now and then to rest your eyes. Other people, as we've applied today, may need an interpreter, and so on and so forth. So again, I'll pause now in case anyone does want to verbally say if they have a particular access requirement, or you can put it in the chat and Maria will help to bring my attention to that. So I'll just give you a moment to do that. Wonderful. I'll finish off by saying that these are some mental health support resources that I'll be sending out after the session today. There's support services on the NETFA website, and also a national network for people who are survivors of trauma and torture. And also you may be an expert on the resources where you live. So please feel free to share any mental health resources with the group. These are some generalist ones that, again, I will send out after today's session. So the structure for today. We are about to go into breakout rooms for about 10 to 15 minutes to get to know each other. And then there will be a 10-minute presentation by Professor Angela Dawson, followed by 5 minutes of Q&A with Professor Angela Dawson, followed by a 10-minute presentation by Monica Diaz, and then another 5-minute Q&A. Then we'll have a 5-minute break. And then we have an apology from the third person who was supposed to present today, which is actually our own manager at the Multicultural Centre for Women's Health, Dr. Regina Torres-Quiazon. Unfortunately, Regina has lost power at her house and is on 10% battery, so she's unable to join today. And she told me to please apologize to the group and said that Mercury is in retrograde and messing with our electronic equipments today. So for those of you who are into astrology. So instead of a full presentation, you'll just be stuck with me, unfortunately. And I'll be doing a brief outline of the NETFA best practice guide and outlining just a few things from that guide. Then we will have a bit more time for group discussion. Unfortunately, Professor Angela Dawson will have tapped out by then, but the rest of us will be here, so I'm sure it'll be excellent. And you'll have a chance to give some lightning updates about what you're working on, any new resources, etc. This might also be a good chance to have a big group discussion about challenges, things that you're curious about, whether to do about FGMC or this network, etc. And then I will wrap up the session with some NETFA announcements, including an update about the NETFA.
Termasuk update tentang NETFA.
Oh, sorry. Eni tadi masuk ke channel bahasa Inggris ya?
Oh, no, I mean in Indonesian.
Oh, hang on. Can everyone hear me?
Yes,
Yeah.
but we also heard the interpreter. Maybe.
Yeah.
Can you hear me now?
Yeah.
I should be in Indonesian. My apologies for that.
That's okay. That's okay. Okay, I'll keep going. So we're gonna go into the breakout rooms now.
Jadi kita akan masuk breakout room sekarang.
Any masih tetap di channel bahasa Inggris. Any.
For some reason I keep switching. My apologies.
Sorry, everyone.
I'll just go back again.
Yeah. Okay, let's try this again.
Can you hear me now, Rani?
Yeah, I can. That's strange.
My apologies. Mine says tick in Indonesian.
Do you want to maybe log out and come back in? Maybe it's just some technical Mercury issues.
Yes, my apologies.
That's okay. Mungkin bisa sama Yowe dulu kali ya.
Will do.
Yeah. Okay. Okay, so I will continue. So we're about to go into breakout rooms. Just one note about breakout rooms. So they're basically on Zoom for smaller group discussions. So when Maria opens the breakout rooms, please click join. And then when you're ready to leave, please click leave breakout room. So try not to click leave meeting because then you will exit this entire meeting. But if you do, don't worry, just log back into the same Zoom link that I've sent out. Okay, I'm gonna chuck these prompts in the chat in a second. So basically in these breakout rooms, we'd love for you to introduce yourselves. You can say your name, the Aboriginal country you're on. This is a lot, so don't worry if you feel a bit overwhelmed, just do what you can. Say your pronouns, any access requirements, and your professional roles. We are joined here today with colleagues from WA, New South Wales, the ACT, South Australia, Victoria. So it's a great national gathering. So please tell us where are you and what are your roles? If you like, you can give us updates on what you're working on, including work that's FGMC related, one thing you're finding challenging, and one thing you are curious about. And again, I'll put this in the chat so that you have a record of what we'll be talking about. So before we open the breakout rooms, are there any questions, everyone? And I'll just stop sharing screen. Any questions? No. Okay. Oh my gosh, you're so onto it. Great. Maria, I think it's time to open the breakout rooms. And we'll be in the breakout rooms for about 10 minutes, everyone.
Alrighty, I'm just about to click open all rooms. So we'll see you all soon.
Great. And Ibu Nika, please stay in this room. So some people will be staying in this room because this is the only room where the interpreters can actually work. So is this everyone then?
Jadi saya mau, can
Hi,
you make sure the Indonesian room?
hi, Rani. I think. Hi, Rani. I think.
Yeah.
Hello, Rani. I think Annie is not in the interpretation mode at the moment, so she's not in the booth. So she is probably selecting Indonesian as a participant, not as an interpreter.
Oh, okay. Okay, let me try and fix that right now. Okay, can you see the invitation now, Annie?
Now she is in the Bahasa. I can see that. Okay, great.
Yay. Okay, so I think this is the small group in here, Lucy and Monette. So I'll chuck in the chat the different discussion prompts, and thank you for your patience as well. So let me see here. Ah, yes, tech. Here we go, I'm working on it. There we go. And I'm going to broadcast a message. Great. I'm Maria, I'm gonna go into the other rooms just to put all those questions in the chat.
I can do that from here, Rani, broadcast.
Okay.
Yeah.
Oh yeah, I just did that as well.
Okay.
Yeah. But yeah, is it okay if I just jump around for a bit, Maria? And
Sure,
I'll
yeah.
have you in here?
Yep, no problem at all.
Okay, that's right. Anyway, so that's me.
Oh, here we go. It's in the chat. Yeah.
Okay.
I had to come into the room with you all. Sorry. So
That's
yeah.
okay. So I've done. Oh, so I've done my name. Yeah. Pronouns, access requirements. What do you mean access requirements?
Things like, do you just need any additional break?
I work.
This meeting is.
Thanks, everyone. Seems like everyone was having really great conversations, and I think we'll be able to hear from all the groups a bit later on. But for now, can I just check you can hear me okay? It's all good? Okay, great.
Yep.
For now, I'm going to hand it over to Professor Angela Dawson for their presentation.
I think, Rani, we might still be waiting on group 1.
Oh, are we? Okay.
Yeah.
Never mind. But Professor Angela, did you want to get your share screen started maybe?
I
We're
will.
waiting.
I will. I'm sorry, I'm not very technically savvy, so forgive me if.
Yep.
Now, can you see that without my speaker notes?
Yeah, it's perfect. Yeah, it's perfect.
Lovely. All right. So let me know when I can go ahead.
Maria, do you think
Yep,
everyone is
we're
back?
good to go. We're good to go now. Thank you, Angela.
Thank you.
Well, look, hi, everyone. Thank you very much for inviting me to speak today. And just to start off, I'm obviously zooming in from Sydney, the lands of the Gadigal people of the Eora Nation. And I just wanted to acknowledge the elders, Eora elders from the past, the present, and the leaders emerging who are going to take us forward into the future. And Indigenous health is a great challenge, and so they are the people we will be working with. And I also just acknowledge our wonderful interpreters here in the room. And so Selamat Sore to everyone, Indonesian colleagues. So today it's my pleasure to share with you the findings of a scoping review that took us 2 years to do. It's just been published. And I've shared the paper with the link with Rani, who can give it to you later, and it's open access, so you'll be able to pop in and download it and get more information. And so this is research that I did with my PhD student Anissa Asifi and Sabra Turkmani. So hats off to their hard work as well. So just to begin, to outline the importance of our mandate as health professionals. I know that there's a mixture in the room today, but not just clinicians, but anyone really working in health. Our mandate really is to focus on delivering high quality, rights-based care. And that's really the goal of all health systems, but in particular, when we're working in the area of FGMC, we're wanting to focus on woman and girl-centered care. And of course, that care embodies feminist principles of empowerment, and is about focusing on the individual needs of each woman and girl. And as you most are all aware of the World Health Organization's clinical practice guidelines on FGM, those are at the core of that document. Just to note also that I've used the term girl-centered here as well, and it's rarely used in our health literature. You may be more familiar with the term adolescent-centered or adolescent-friendly. That's again the WHO, the World Health Organization, often uses that in terms of clinical and service settings. But these terms really embody the concept of autonomy. So respecting the wishes and the values of the user, the health service user, and focusing on the importance of involving people in their own care decisions. So those decisions are often aligned with what we call patient-centered care, also people-centered health services, and consumer participation. And these terms appear in different spaces in the health world, but they really are principles about moving from standardized disease-orientated models to more holistic and tailored partnership approaches with the people. And it's really about a shift in power during healthcare interactions. So you can see this snapshot from co-design tool here from a little animation where we see the often doctor, male, with a desk, and then the people on the other side. So really it's about reorientating that interaction. And we often call that, you know, the changing the terminology from clinicians and patients. We know that there's lots of evidence for this approach of the patient, consumer, client-centered care. So for example, the Institute of Medicine in the United States has found that putting people at the center of their healthcare leads to more satisfactory, safer and higher quality care, which of course improves health outcomes. And there are a number of systematic reviews, if you're interested, I could share those with you, that show promising effects in terms of chronic disease management and increased patient self-esteem and independence. So in Australia, patient-centred care is obviously supported by both national and state directives such as the Australian National Safety and Quality Framework. And in all health services, it's linked to service performance and funding. So we have to do it. But health outcomes for women are not always the same. So, but with the right care, and I'm going to refer to pregnant women a lot because I do work in the maternal health space. So apologies if I bring those references to there too often. But we do know that with the right care, pregnant women with FGMC can have the same health outcomes as women without FGMC. And we know this from one study. It's a study that I was involved in, a cohort study that looked at the perinatal, the outcomes, the health outcomes for mothers at a large hospital in Sydney. The outcomes of 196 women with FGM who gave birth between 2006 and 2012. And we compared those with women who did not have FGM, who gave birth during the same time frame. So that study was working with a prevalence of around 3% of women giving birth in that hospital who had FGMC. But what we found is that with trained health providers, so there's a special group of trained midwives caring for women with FGMC, who counselled women very early on antenatally about antenatal defibrillation, especially for those with FGM3, and followed them. Those midwives in the room will be familiar with the term continuity of care. So looking after those women throughout their maternity period, they had similar outcomes. So there was just a little change in terms of perineal tears and caesarean sections, but those caesarean sections weren't indicated. They had no relationship with the woman's FGM. So women with FGM can have the same outcome. So we do know that. So quality care is central. But health outcomes are not always equal. So from some other studies shows that refugee women born in countries where FGM is prevalent are more likely to present late in labour. Oh, sorry. Can you see that, by the way? Is that coming down on the slide? Yep.
Yes.
And higher rates of stillbirth and episiotomies and severe perineal trauma. So we do know that that women may require more stitching, for example, and may have issues during their birth. And Australian paediatricians are seeing children with FGM, and I'm very happy to provide you with these references. So obviously, presenting to a paediatrician means
Excuse me, Angela.
Yes.
Just letting you know, you've got another 5 minutes.
Oh my goodness. All right. So there are problems with care, obviously. So despite the differences in health outcomes, there remain issues with care. So women aren't satisfied with the care they receive. The minute I was circumcised, they said it made me feel like I was from another planet, and judgmental judgments, from health providers. And we have we've undertaken a systematic review which shows basically lots of issues relating to communication, lack of power, etc. So quality care is best achieved when health workers understand the woman's socio-cultural context and her values, preferences for health. Shared decision-making is key, and decisions need to be made based on what matters to women. Tools can be really important, but we have no real knowledge of such tools. So just to make sure that we're all across what we really define as woman-centred and girl-centred care, I'm just sharing with you this model. It comes from a systematic review by this group headed by Scholl that defines care according to 15 dimensions and grouped into principles, enablers, and activities. And so principles, for example, are things such as, does a clinician have empathy? Is a relationships trustful, caring, etc. Is a teamwork, and lots of activities that are around provision of timely information, the patient empowerments related to recognising the active support of the patient's ability and responsibility to manage their own care. So here's our research. There was a real gap. We used this model that I've just told you to identify aspects of patient-centred care. And we searched databases for websites of health professional associations. We focused on these countries and we appraised these papers. What we found, 124 documents were included in the scoping review, 88 mostly were from the UK, 20 from Australia, and 9 from the US, 3 in Canada, 2 from New Zealand, 2 from Ireland. The types of documents really focused on multi-agency safeguarding and mandatory reporting tools, clinical management, professional guidelines and statements. Only 12% of the included documents included references to all principles I've just shared with you of patient care, and only 1 document spoke to all the principles and enablers, and 9 only referred to the involvement of women and girls in the development of those tools. That's sobering. I know you can't read this, but what I'm trying to show you here, that out of the 124 documents, 15 only contained information that was consistent with the all of the fundamental propositions, or the three key groups that you see here. And only one document, which is highlighted in purple, you can see ticks across all of the areas known to align with high quality patient-centred care. And that is from the UK, and I can share that with you later. So just to note, out of the 124 documents, only 12% contain information about all the aspects. You can see only one document discussed holistic integration of medical and non-medical care, and only 9 identified aspects related to patient empowerment. So pretty sad, really. Take-home messages. There are a lack of women and centred tools and guidelines in the area of FGMC. There's a need for women and girls to co-design guidelines and tools and to evaluate them. And I suppose the next step really is looking more closely at how we can work with women and girls with FGMC to co-produce healthcare. I don't think anyone find this surprising, but there's a need for health professional training to deliver those tools, and organisations to support the implementation of such tools. Thank you very much.
Thank you, Angela, and a big round of applause. Thank you so much, and apologies that I felt like you had to go turbo the last 5 minutes.
Sorry about that.
No, it's all good. Thank you. That was exactly 5 minutes. We do have a few minutes now, everyone. If you do have any top of mind questions that you'd like to ask Angela, feel free to either turn on your mic or you can put the raise your hand function. Go ahead, Lucy.
Angela, I'm interested, was there consistency in mandatory reporting tools and guidance across the board in those documents?
Off the top of my head, the majority of those tools were from the UK. And yes, there was consistency in the UK ones. It's very interesting what I would say the UK leads the space here. Really the Department of Health and Department for Home Affairs, sorry if I've named them incorrectly, have standardised guidance that has been taken on board and tailored by health services and councils. And there is really nice approach to I suppose, multidisciplinary cross kind of sector working. So the tools and guidance in that space are informed by very clear legislation, safeguard enshrined in law, and guidelines that have been put out nationally that have been taken by various health services and councils and integrated into their tools. So there's consistency, yes, short answer. Not in the Australia, very few in Australia, and zip in the US, none in Canada, none in Ireland from the top of my head.
Thanks, Angela. And yeah, any questions or comments are welcome. I know we all
email me, please. Feel free to email me if you want to chat. Very happy to. Thanks.
I think Maria, you want to ask?
Is there time for another quick question, Rani?
Yeah, there is. Yeah.
Thanks so much for that, Angela. I was just wondering, one of the enablers that you identified was access to care. And I'm wondering if you could explain that a little bit more.
Okay, yeah, that is, I've just got the this Scholl's categories in front of me. That is about the facilitation of timely access to healthcare. So that's really about decentralized services. So maybe outreach, things coming to someone's home, so home visiting. So we do that a little bit in child and family health services and in the first newborn visits that midwives make, but it's very extensive in the UK. So yeah, it's if that makes sense.
Yeah, I'm just wondering, does it speak to any kind of broader structural issues around cost, or is it, yeah?
Look, I think all of these tools and guidelines, of course, are the product of the health system and the community service system in which they're developed. So that's why I, in response to Lucy's question, highlighted the British model, UK model. Of course, that doesn't include Scotland. It's mostly focused on Wales and England. But when you have a consistency across national health and community kind of sector services, you get a better tool or guideline. And when there's buy-in from professional organisations in the creation of those across nursing, midwifery, obstetrics, gynecology, and social work and psychology, then you hit the jackpot. And that one that I highlighted in purple really actually demonstrates that beautiful coming together of different professions. We've got a lot of work to do in that area in Australia. I can't speak for the rest of the country, but certainly New South Wales.
Thanks, Angela. Thanks for the questions and comments, everyone. This is actually a really good segue for our second presenter, Monica Diaz. So Monica, would you like to start sharing screen? Because I think you have some excellent international context that you'll be sharing. Oh, and also our manager, Regina, was able to join us after all. So hi, Regina.
Hello.
So thanks for, yeah, I'm so glad you were able to join us. And Monica, did you want to share your screen? So we'll do a 10-minute presentation with Monica and then a short break before coming back with Q&A with Monica. Does that sound okay, Monica?
Yeah. Can
Awesome.
you see that full screen?
Yes.
Like the whole thing? Excellent, the presentation.
Yes.
Great. Thank you so much, Angela. That was really good, and it leads in quite nicely to what I'm going to talk about. So, and I would like to thank NETFA for allowing me to present here today. I really appreciate it. And I'll also like to acknowledge the country. I would like to acknowledge the traditional owners of the land that I'm currently in today and everyone else in. We're in Ghana land, and pay my respects to the elders past and present, and extend that respect to other Aboriginal and Torres Strait Islander people who are present here today. So just a quick background. I'm a clinical midwife and nurse at the Women's and Children's Hospital here in Adelaide, and I'm also a PhD candidate at the University of South Australia. And my work is around FGMC. So today I want to really briefly present to you the findings of a Winston Churchill Fellowship. So I am a Churchill Fellow as well, that I did back in 2018. So just a bit of background at how this project came about. I was working in 2016 with the University of South Australia, Wounds Healing Institute Australia and Wounds CRC on developing a program, education program for clinicians around perineal trauma and in childbirth, and how do we prevent that, and how do we support clinicians to ensure the best sort of care for women. And during the research phase, we found that women who have had FGMC are at increased risk of severe perineal trauma. And it was something that we hadn't really thought about. So we started looking at our clinical guidelines and clinical practice. And we found that there was a very brief mention about it, but there wasn't anything that clinicians could go back and go, what do I do? How do I support women? Those sorts of things. And then we looked at around nationwide, and we found a few pockets of information and some of the research that's been done in Australia, but still we didn't kind of feel that we had enough to go by. So I applied for some funding through the Winston Churchill Trust to explore the care and support of women who've had FGM, in particular the support that they get during pregnancy and childbirth. Being a midwife, this was quite a significant thing for me. And so today I won't be able to get through the full report. It's quite extensive, but if you would like a copy or would like to know how to access, I can certainly send you the link, or go to the Churchill Trust and type in my name and you'll be able to find it. So in 2018, I went to Europe. I traveled for 6 weeks and I visited 5 countries and a number of organizations, clinical services, and also attended a forum. The things that I found were, like, my highlights, I guess, were I was able to be present in some of the clinics that they run supporting women, which I thought were fantastic. And as Angela said, UK, England in particular, has the best sort of model to this stage at the moment about the work they're doing. FGMC has been illegal there since 1985. So since then, they've done quite a lot of work supporting women, supporting communities, and also ensuring that health professionals have the knowledge to be able to do this work. The other highlight was visiting the National FGM Centre in England, which is a centre that provides a lot of education and resources for professionals and communities. And it's something that you can even access from here, and you can have a look at the resources. It's quite extensive, evidence-based, and they work with communities. I also went to Switzerland, and the highlight there was meeting Dr. Jasmine Abdukari, who is I guess, leader in the research around FGMC, in particularly clitoral reconstruction and all those sorts of things. So it was really an incredible experience for me to be able to listen to all this information and bring it back. So like I said, I won't be able to give you a full rundown of it, but this is sort of what I thought might be something that people might be interested in knowing. So from when I visited, I got to be present in antenatal appointments with women. So women allowed me to sit in their antenatal clinics and listen to how the process of having the discussion about FGMC happens. And that was really good. It was really interesting because what I found, especially in England, every maternity service has a standard that you must ask all women, regardless of the background, their FGM status. And then those women who have had it or are considered, may possibly, they're not sure, but they still want to have a chat to somebody, they get referred to a FGM expert, and that could be a nurse or a midwife or a obstetrician. And they attend this service, and it's about an hour and a half. And women are given support by the midwife. They have a chat about a discussion around FGM and about any implications, like health implications that they have, and how can we manage and plan for their pregnancy and birth. They also have referrals to an obstetrician or gynecologist if needed, depending on what stage they're at. Every clinic has a community health advocate, and that is absolutely essential for the services to run, because it's their link to the community and to ensure women feel comfortable and safe, and that any sort of cultural misunderstandings are picked up by this person who can guide the clinician to, like, maybe this is how you need to discuss this. Women also have access to social workers. So it's not only about their health needs, but they also ensure that they provide support in the community. So if women are struggling with housing or financial issues or anything like that, they have that support as well. And quite importantly, also looking at mental health. Mental health is a really big thing, and all services had access to mental health, in particular psychosexual counselling, which I thought was quite interesting, that it's a very holistic sort of service and multidisciplinary. So there, most of the services are provided in the hospitals or in the communities as part of like a community centre. Women can be referred to the services or they can just drop in. It's not essential that they have to have a referral, they just can go in. UK also has the FGM Enhanced Dataset, which is a reporting tool for clinicians to report FGM cases within the that health service. And it's de-identify information that goes to the government that tells them how many people are in the community, and then that way they can sort of move the resources, financial resources, to those areas where they need more support. So take on findings.
Monica, this is Rani. This is your 5-minute call.
Sure, thank you.
you.
So just yeah, so things to take home, I guess something that we can learn from it is that in the first antenatal booking appointment, it's quite important that we engage with women, and we ask all women regardless of the cultural background. I heard a couple of stories in Belgium when I was there that clinicians have said that there are people that marry into those practicing communities, and the women actually want to, as part of the initiation to the families, they will go back and have FGM. And so they said you can't discriminate and everyone gets asked, which I thought was quite interesting. A woman's country of birth and family background is the strongest risk factor for FGM. So it's important that we ask everyone. And also we got to remember that some women don't remember the experience. It was done when they were quite young. So we need to be sensitive that that may be the case as well. The other thing that was really important, and I think it's important in our, as part of clinical practice, is that we are sensitive and we are culturally appropriate, that we speak in a manner that is respectful to women, and ensure that we communicate with women and we ask them, how do they want to talk about this? Do they want to do that? And what is their language that they prefer to use? I was at a conference and I remember during the question time, one of the women stood up and said, I'm a circumcised woman, not a mutilated woman. And that really sort of made me think, yes, like the way we talk, and I understand the reasons why it's called FGM, but you know, we have to be respectful of the women, and that's really important. Just a bit of a content warning. The next slide has a drawing about FGM. It's quite small, but if you want to take time away for this moment, please do so.
And I'll just jump in here. If you do want to take time away, as Monica said, just let me know in the chat and I can message you when we're ready to come back. When she's moved on, sorry, when Monica has moved on from the slide. Thank you.
Okay, I'll move forward. And one of the really important things, and pretty much every country that I visited, and that included Wales, Ireland, Belgium and Switzerland, they had some kind of pro forma, a document where the midwife nurse discussed a plan for women's care, in particular during pregnancy. And they were offered an assessment if they wanted to. Women didn't have to have an assessment. They collaborated on a management plan, in particular for women with type 3 FGM. They were offered defibrillation, and the option was either defibrillation antenatally or during childbirth, during the actual labor process. And there were specific steps around that. They also talked about any referrals that the woman may need and any follow-up in the postpartum period. And the reason for this document, it goes into the women's case note, is that so that everyone lines up with how we're going to look after women and what the woman wants. It's really, I guess it's annoying if you don't have this documentation that everyone's asking the same questions and no one knows what's happening, and that really confuses women, and it also makes the experience quite uncomfortable as well, because everyone's asking, everyone's looking, and that's really not ideal. So we need to make sure that we're all working together and we're all caring for women in the same manner. And there was quite a few more things, but because I only have 10 minutes, but like I said, if you want to have a look at the report, it is up on the Shield Trust website. These are some of the resources. Like I said, the National FGM Centre is a brilliant place to have a look, as well as NETFA. NETFA has quite a lot of Australian related resources. But if you want to look at different things, there's also the FGMC visual reference tool and learning tool, and that can be quite handy to as a starting source of how to discuss FGM and those sorts of things with women. And that's it. Any questions?
Thank you, Monica. This is Rani again, everyone. If you don't mind, I think we'll go on a 5-minute break now, and then we will make time for people to ask you any questions.
Sure.
Is that all right?
Yeah,
okay.
No problem.
Awesome. So everyone, if you can come back at either 10 past or 22 if you're in Central Standard Time. I'll play some music again, and we'll see you in a few minutes. See you soon. Maria, do you mind staying on just to check my sound levels? Thanks.
Sure. Do you need me to stay on, Rani, for a bit? I'll just...
No, I think it's okay, Regina. I'll just bring you in once we're done with questions with Monica.
Oh, okay. I'll stick around. I'll just turn the camera off.
Yeah.
Okay.
That's good, Rani.
Maybe turn on your video if you are back, or put it in the chat that you're back. I'll just give people a minute. And can I also ask everyone just to check that you're still in the English language? I was told by my colleague Delaram that everyone might have gone back to the original audio. So if you can just check on your bottom bar on the interpretation button, click on the globe, and then go back to the English channel. And welcome also to Catherine, who joined us a few minutes before Monica's presentation ended.
Hi, everyone.
Hi. Welcome. Thanks for being here.
Thank you. It is a pleasure.
So it looks like I think most people are back. We do have a few minutes to ask Monica any questions about their wonderful presentation. So I'll open it up to the floor. Yes, Felicia and Karen, go ahead.
Hi there, thanks so much for your presentation, Monica. I was doing a little bit just an assignment at uni last year looking at FGMC, and one of the things I came across was sometimes some women request reinfibulation after birth if they've been deinfibulated because that's what they've known, and obviously there's a difficulty with that because clinicians are then not allowed to perform it. Is that something you've come across in your research, and how is that managed?
Yeah, great question. Thank you. Yeah, it has come up in clinical practice for me. I've had a couple of women asked one was a woman who asked, and then the other one was a husband. And we spoke to them and we discussed about our legislation and how it is illegal to do that in Australia. And there are also laws for people going overseas to have it done. And so it's a lot of counselling around that and having that discussion and being open about it, because I think a lot of the time people don't know what our laws are, especially if they're new arrivals. They don't understand, and that's why it's important to have that as clinicians, for us to understand that we can talk about it, but in a culturally sensitive way, I guess, and inform people. That's our role, to educate people about how we do things, and yeah, best management practice.
Thank you. Any other questions or comments? Not at the moment. All right. Thanks so much, Monica. Again, big round of applause for a wonderful presentation. I'm going to invite Regina now to present. So Regina, go ahead.
Hi, everyone. I might just start sharing my screen. And can everybody see that?
Yes, you're not in presentation mode, but yes, I can see your slides. Yep.
Is that better?
Oh, has that gone?
I have
wonky
had
for anyone else?
Wi-Fi issues today. As you know, there was a power outage, and my Wi-Fi provider let us know that is that clear? No.
Is that coming up double for anyone else? Yeah, it's coming up double. Yeah. Oh, that's really weird.
Yes.
I reckon, do you want to shut down PowerPoint and try again, Regina? And I think it's just the Mercury vibes.
It is the Mercury vibes. Let's have a look.
You can also send it to me, Regina, and I can share it if it doesn't
Has
work.
that happened?
That's better. That's better.
It doesn't look good on my screen, but okay, let's go, because I only have 10 minutes.
It's all good.
Thanks, everyone. My name is Regina Torres-Quiazon, and I'm currently the National Program Manager on a COVID-19 vaccination project. But a few years ago, I was the Senior Research and Policy Advocate, managing one of our FGM prevention projects. So I have been asked to speak about the best practice guide in relation to that work that we did long ago. And I might just, there we go, I have to go to the next slide, but it's not, can you see it?
No, not for me at the moment, Regina.
Okay, there is a beautiful slide that I had put together. Oh, okay, never mind.
I mean, you could try presenting without being in slideshow mode, maybe, Regina, because I could see your slides earlier.
Oh, okay. Well, why don't I just talk by the time? Yeah, I apologise for the technology. So hopefully at this time of the day, you all feel that it's not too boring in terms of best practice principles, because I did think about when Rani had asked me to present that it had been a while ago since I did do this work. And I did not want to read out each best practice principle. There are 9. And I did put up the slide because you can find that on the NETFA website as well. So, but I did want to talk about a little bit of background in terms of how that had come about, because back in 2013 BC, I'd like to say, before COVID, there really wasn't anything in Australia in terms of how we should do FGMC prevention, especially from a migration point of view. So I really wanted to stress, even back then, we thought, how are we going to work together? What are the best practice principles when there wasn't a lot of work being shared at the time, which is, you know, close to a decade now. So I wanted to provide everyone in the next 8 minutes now my reflections as to, in I guess the preceding 6-7 years since the time, you know, we originally had put the guide together. What have I learnt as a practitioner? So I joined MCWH back in 2009, so 13 years ago. And I have to say that, you know, the whole concept of FGM was pretty alien to me. So I had originally come from academia, doing research specifically on diabetes education and prevention when I started at the centre. So when we received this funding back then from a Labor government, I must say, I really didn't know a lot. And I was actually feeling a bit nervous and anxious about taking carriage of a project that I felt, especially in terms of MCWH's approach, really should be led by communities affected by that practice. I knew that. So in saying that, I think we need to think about the best practice principles and the guide, which I hope some of you have already read. So I'm not going to be reading them out. But I think we really need to think about it in terms of the value. So not values as such in terms of, you know, principles or standards, but really value in terms of the dictionary definition, that it is something that we have to hold in high regard and see as an important document and something that is useful in terms of our day-to-day work. So when we talk about principles, we often talk about, you know, ethics and the moral ethics in terms of how, you know, we should implement activities in relation to FGM prevention. But I think underlying any talk of ethics or moral principles is really that, you know, that philosophical question, how should we live? But in this case, it's how should we all work together to do this work? So there are 9 principles in terms of, you know, what we can and, you know, what we should do to work together. And I wanted to talk about each of them in terms of what I've learned in the last 8 years since putting it together. I did have a slide of the original draft, the cover of the best practice guide. And it was very interesting, even in terms of the editing that was involved in that guide. It really demonstrates in itself, you know, the things that we've learned about using the appropriate language and meaningful language around engaging communities, and even the approach that we use in terms of looking at FGM in terms of not who practices it, but actually who has been affected by it. So they're, you know, they're 2 very different things. So 9 principles. I don't know how many minutes I've got, Rani. But the first one is around community engagement and dialogue. And when we talk about dialogue, it really is about listening, radically listening to the communities that we work with and work for. So what I've learned with this particular principle is that it's not just enough to listen, but it's also about encouraging others to be part of that dialogue and supporting them and facilitating that dialogue to continue around particular activities with FGM prevention. So that's the first, community engagement. The second principle is community leadership. And I know this has been spoken about quite a bit in terms of ensuring that we have the communities who have been most affected by FGM to lead, and also because it is an issue of gender inequality or gender equality, depending how you frame it. So it really is about creating and fostering meaningful opportunities for that community leadership to happen. Because it is really easy to say, and it's almost like we may shift that responsibility in terms of doing the work in this space to those communities most affected. But our work really is to create and foster those opportunities. So the third, and it's pretty much related to community leadership, is women's empowerment. And this, I've learned, is really about investing, building, and really developing the self-belief in women to act on those issues that are most meaningful to them. So I guess I hope you've picked up by now in terms of the lessons that I've learnt in putting the guide together. I've been using action verbs instead of keeping the principles quite static in terms of a statement. So number 4, and this is really about holistic and integrated in education. And I think you may have already spoken about it this afternoon, that we really can't talk about FGM as FGM. And if we are to engage other communities, we really need to frame the practice within a wider context, such as women's health and sexual and reproductive health and rights.
Susie, Regina, this is Rani. This is your 5-minute call. I'm giving you a few extra
5 to go.
Because of the tech issues. So yeah.
No problem. 5 to go. So the 5th is professional peer education and training. And we know, the evidence suggests that social change, especially around health issues, can only happen if we have participatory peer approaches. But what we need to do in that field is really support, to supervise and recognise the fact that peer education is just as professional and can be professional as other approaches. And the 6th, which I think that there really needs to be more discussion, and you could probably have a whole seminar or a whole day forum, and that is about cultural dignity. And really, cultural dignity is about respecting cultural dignity. And I've got to stress that it's not the same as accepting cultural practices without question whatsoever. So I suggest you read the guide on that. And we also, MCWH, have also produced other resources looking at the complexities around culture and what we mean by culture. But in terms of FGM, I think we really need to can't accept that, we need to question cultural practices, but to ensure that we respect people's cultural dignity around that. So number 7, and which is why we're all here today, is really we're building the capacity of relevant professionals in this field. But the key message around this particular principle is really we need to advocate for improved services. You don't have to have advocacy in your job title or even in your position description to do that, as we know. Each of us has a role to play in each of our organisations to look for, it could be a policy, it could be a particular way that your organisation is doing something that is perhaps not as accessible, not as culturally meaningful for women who may have been affected by FGM. So I think it is our responsibility to point that out within our organisations and to advocate for the change that's needed. And number 8, of course, is collaboration, and I think most of you would know that. But I think we need to build closer bridges, and I think we're doing that here now, especially with a forum like this, and really just accept that none of us, you know, work in an FGM vacuum, and if anything, FGM we need to place. Again, I mean, these principles overlap and intersect with each other. In order to build those bridges, we don't only simply have to frame it within a wider context, but we also have to let those other organisations or people that we work with more clearly understand what that means in relation to the work that we do together. And number 9, and it's always research and evaluation. And we all know in terms of at the pointy end of getting funding for the projects that we want to work, in terms of the projects that we need to do in order for women who have been affected by the practice, in order for them to receive the health services that they need, we need the research and the evidence to change policies and to make that structural change. So we need to document everything to share that. So Monica and Angela are doing that, so that's great, and I'm glad that we're having this conversation now in terms of bringing those issues to the fore. And I'm hoping, Rani, I think after this we will be documenting the conversations and the issues and the questions that have been raised. So the best practice guide really isn't static. There have been 2 revisions of the guide now, and I expect possibly in the next 2 or 3 years that there will be another revision because our policy and political contexts are changing. And I think we need to make sure that the guide, like ours, continues to live on and to be used by each of us. So I think
Thanks,
that's it.
Regina.
Thank you. Is that the 10 minutes?
Yes, perfect timing. If you don't mind, just stop sharing your screen, and then we do have a few minutes for any questions and comments. And also, Regina, is it okay if we send people the slides instead after this?
Most definitely. Yeah,
Great.
most definitely. So
I can still see your desktop, which is very unusually.
it's very, I apologise because my Wi-Fi has been playing up since the power outage. This is very...
All good.
That's all right, Regina. I stopped sharing for you.
There you
Thank
go.
you.
Awesome.
I should have sent that. I will send it out.
Yeah, all good. So we have a few minutes now, everyone, for any questions or comments or reflections.
I did have a beautiful umbrella at the end of that PowerPoint, a beautifully coloured umbrella, because I was about to say the best practice guide really should be used as your sword and your shield. But I thought, oh, can I think of something, a less violent kind of metaphor? So I thought a brightly coloured umbrella in stormy weather, pull it out, because the best practice guide is even colour coded as well. And yeah, I see a few questions.
Yes,
Yeah.
I'm gonna go to Monica and then Lucy, and I can also see in the chat Felicia and Karen said appreciate the reflections and discussion around the guidelines. Thank you. Go ahead, Monica.
Hi, thank you, Regina. That was really, really good, really interesting, and I have read the guide before. I'm just wondering, how is the support from, I guess, the government to ensure like things like NETFA and any sort of education and community support is maintained, like because I know that this started back in 2013, is that right? Around
That's
that
correct,
era. And I read somewhere at some point that government was cutting down some of the funding, and I think that's really sad because we need that support to continue. So how are you finding that? Like, what is the actual current stance on that?
Yeah, well, we're, the current iteration of NETFA is being funded for another 2 years. Is that right, Rani? Is there anyone here from government before I say anything? Is there?
Is this where I should stop recording?
No, that's fine.
Okay.
No?
Not as far as I'm aware, unless I missed that info. No, I don't think so. Yeah.
No. Oh, okay. Well, look, I can say that, yes, so 2013 was the first stage of NETFA, and that was funded by a Labor government. But since 2013, we have continued to receive, and I think this is the third round of funding that we've received money from a Liberal national government. And at first I thought that's quite curious that we would receive so much money, admittedly, from a Conservative government on this issue. But you could probably guess yourself why we've received that amount of money under a Liberal government. There continues to be a perception that FGM is still a primitive practice and, you know, needs coordination and support from a multilingual organisation that works with these communities who continue to practice something that is seen by some levels of government as still quite primitive and barbaric. Yeah, which we know isn't the right language to use or the right approach, but for better or worse, that has perhaps been the reason why it has been funded. Again, we continue to do that the work in terms of framing FGM within that wider context of gender equality and sexual and reproductive health rights. So, but it's a tricky balance. Yeah,
absolutely. And yeah, absolutely. Thank you for that. Yeah, and that kind of lines up with what I'm finding in my current research, and even when going through ethics, and part of my study was talking to women about their experience in accessing health services, and ethics are like, oh, you're going to have a really hard time getting women to talk to you, and there's not enough women in South Australia with FGM and all these things. And as it turns out, I have 10 women who were quite happy to talk to me about their experiences with health services, but I found it quite I guess I was taken aback by the fact that I'm like, from, you know, ethics and from, you know, even my own workplace, they're like, oh no, like this work is not needed, but it clearly is. The community is saying one thing, and, you know, people in, I guess, power and control are saying completely different things. So that's really interesting. That sort of lines up with what you're saying in a way.
Yeah, and again, it's about the framing, isn't it? It's like, when we talk about need, what is the need that's being defined? Is the need being defined as it's a cultural issue that only pertains to particular communities who don't look Anglo-Australian, or is the need about ensuring that we have accessible, equitable health services for all women? Yeah.
Thank you. Thanks, Regina. I'm conscious of the time, so we only have a few minutes left for more questions and comments. So I'm going to hand it over to Lucy now. Go ahead, Lucy.
Thank you. I'm just interested in the first point that you spoke about, Regina, because, like, in principle, I fully understand why it's important to incorporate all levels of community in project design, but practically so difficult. So can you speak a bit more, I guess specifically I'm interested in how to engage men in this conversation, because to create community change, that's what we need. But I think for me to run a sexual health and reproductive health education course for young women from refugee and asylum seeker background, the approach that SHQ and I have used is to get input from the young women themselves. The thing we didn't do is get input from elders in the community or others in the community. Yeah, because practically I can just see all of the challenges.
Yeah, but I think we've got it, but practically that is the challenge, the practical implementation of that. So is your question, Lucy, about engaging men? How do we engage men?
Yeah, or what's your experience been in that process of wider community engagement around project design?
Around project design. Oh, we've actually got a current one where we have to, men are engaged in our health education training, have been. It is about, so it links to the principle around women's empowerment. So I think we've got to ensure that men themselves understand that this issue around being allies, and that women in this space need to lead. They can work with women in the space, but they will need to do it under the leadership of women. So work with men on a, so you wouldn't specifically begin with, you know, FGM prevention straight away. It would be a separate process of engaging men first. But it's a, I mean, yeah, I can send you some materials on that, but it's at different levels. So when you say the difficulty, I don't think it's difficult to engage men, but I think the difficulty will come in the practical implementation of it. Yeah.
For sure. I guess our experience at Assets has been any conversations with older generation. I work in the youth program, so my experience is that any conversations with older generations about talking to young people about sex and reproductive health, it is no, you do not speak about that with my young person.
Okay.
Yeah, so I guess talking about FGC on top of that, it is more difficult potentially.
Yeah, so you would be talking about other issues first and maybe having some foundational conversations. It could be, I mean, talking about the generational differences, even though, yeah, I don't think we should go into generational arguments and differences, but they are there. It could be a start. So it wouldn't be sexual and reproductive health and FGM as the focal point. So gender equality, talking about gender inequality is a challenge in itself, but there are a lot of resources at the moment that could help support those conversations. So I would advise beginning from there. Yeah.
Thanks, Regina. Kathy, I can see your hand, and I just want to introduce the next part of the schedule, you know, what we're going to do today, in case this is relevant to what you're about to say as well, Kathy. So we do have a few minutes set aside to give each other some quick updates about what you're working on, any new resources on FGMC and otherwise that you want the group to know about, any challenges, which again, some of you, including Lucy, have been voicing that you'd like us to try and address maybe through our collaboration at NETFA. So Kathy, I will hand it over to you, and then I'll give people some time to think in case there are any updates you want to give to the group.
Yeah.
Go ahead, Kathy.
Thank you, Ronnie. Hi, Lucy and everyone. I'm working in a maternal health project, and I am finding that has become such an easy channel. It's come so very naturally. FGMC has just come as a natural, it bubbled out of our maternal health project, and we are now working with many communities that are just talking to me about it all the time. So I'm like, oh, I'm under-equipped. And so it's just been this natural bubbling out once you start talking about maternal health and adolescent girls and all sorts of things like that. It's just bubbled out naturally from that project. So I don't know if that helps you any, but that seems to be where I've got most of my conversations anyway. And it's been regular, like every time I speak to a group of women, it's like they just talk about it, which I'm like, okay, but the men are part of it, but not in those groups, if that makes sense. So they've given, you know, they've almost given approval and do this is wonderful. And it's just come out of that naturally. So.
Thanks, Kathy. I'll just take a moment to remind everyone as well, this hasn't happened, but in case you joined us a bit late, we did set some ground rules around group discussions. So please make sure you don't share any graphic content, you don't share any graphic stories, and you are not, you don't have to share any personal experiences of FGMC, but if you do want to share, do a content warning. So say to the group, I'd like to share about my personal experience of FGMC. Any other comments, everyone? Comments or questions you have for the group? I'd love to hear what was shared in the small group discussions, for example, you know, in terms of, I feel like we've heard about challenges and also things that you might be curious about that you think NETFA could try and explore or address in our work together. Or people might be very zoomed out. No?
It's very late in the day, Rani.
It is. Everyone's probably like, can we go now?
Rani, do you want us to go around all of us now and share a little bit about what we're doing in the space?
Sure,
Sorry,
yeah.
I got confused.
Oh, that's okay. Yeah, so we have a few minutes to do that, Felicia and Karen. So actually, I don't know the two of you very well. Did you want to describe the context that you're working in, maybe?
I've put us in the spotlight now, haven't I? And we're probably the least experienced people in the room. I'm Karen, this is Felicia. We work for Sexual Health Quarters, which is Western Australia's Family Planning Association. We are not clinicians. We don't present education around FGMC specifically. We do work with young people and provide education in community around sexual and reproductive health, rights, access to rights, and everything from bodies through to contraception, consent, respectful relationships. So while we don't present specifically on this, in the work that we do with young people, yes, this comes up. And we work very closely with Lucy on your screen, who works with assets, and I might let her speak more about assets. But we have a beautiful partnership with assets where we work with young women and young men from backgrounds of refugee migrant experience. So I guess for Felicia and I, joining you all today is very much learning and checking in to ensure that our educators are endeavouring to be best practice in the work that we do. We see very much our role as being educated ourselves, so that if this topic does come up, if it is raised, and which it does whenever we talk about bodies, for example, when we talk about first sex. I note that there are many people in the room where these conversations, as you so beautifully described, bubble up when you're a midwife or a clinician or a nurse, and I can see how that's the absolute best place for it. We work with young people where we talk around bodies and puberty and growing up and sexual health and first sex and what is sex safe and pleasurable. So for us, it comes up in that context, which we're very pleased that it does, but it can also be very challenging. So we're here so that we can ensure that when those conversations come up, we respond appropriately, and we see our role as connecting young women into the appropriate referral pathway, the appropriate clinician if they need it, the appropriate specialist youth worker like Lucy or whoever.
Yeah, thank you. Thanks, Felicia and Karen. That was a great introduction to what you do. And we probably won't have time for everyone to do an intro. So I'm just going to jump around to make sure we've got someone from each state at least. So Faye, if you're up for it, can I ask you to say a little bit about the work that you do in the ACT?
Yeah. Can you hear me?
Yes.
Yeah. Hi, my name is Faye. So I'm Women's Practice and Inclusion Nurse and FGC or FGM. So Women's Health Service has been given like a budget / portfolio on FGM. So that's why, and it's part of my role, which is health promotion and health education. So I do cervical screening test or well women's check, and I see clients who have had FGC or FGM. And whenever I see clients who have experienced FGC, is I would refer just of course with the consent of the client, we refer them to continence nursing. And if there's any issues on any urological issues, we refer back to the GP and they would be referring to a urologist. And also we refer them to a social worker and at the same time a counselor that's also trained on FGM. If they want more education, so we also liaise with Medina, who is an educator with multicultural, I forgot the whole
Center for Women's Health.
Yes. So Medina has conducted Zoom sessions individually with our clients. And I think part of, in terms of the challenges with men, I did encounter where it's actually the husband that was advocating for their wives, just because they have a different concern or a symptom, which is a decrease on libido or recurrent UTI. And so that's why I didn't have that much challenge in terms of men, because they were the ones who were actually, advocating what's wrong with my wife. And then we have to link, all those stuff, and also partnering with the GPs. So there's actually a particular GP that, is actually sending his clients who have had experience of FGC into our service. So I've just noticed 5 of my clients who have, was really referral coming from that particular GP. So I think that's also one good way of establishing that support for these women.
Thanks,
so,
Faye.
Thank you.
Thank you. That was a great intro to what you do. I'll invite Catherine just for a final introduction. And then if it's okay, Catherine, I'm going to jump in the final 5 minutes with some NETFA announcements. Thank you. Go ahead. Oh, and you need to turn your mic on. Hey, there you go.
Hi again. My name is Catherine. I'm a registered nurse and a registered midwife at Westmead Hospital. I'm talking about FGM. Now, I'm really interested in it. That's why I got into contact with Auntie Juliana for her to, just to mentor me, because I've been doing this for quite a while, because I work in birth unit and in the women's health sector and maternity ward, you know about it. So I took this opportunity, just to know what's going on, what you guys are doing, so that I can join, and then so that I can join you guys and then put in my input. Because I'm not just a midwife, I'm also part of the obstetric and gynecology research team. So I'm looking forward to this, because I would like to really put in my all just to make sure we eradicate this dreadful practice. So it's more about education, because I've done few. I was an acting educator, and I love teaching. So I really want to educate clinicians and also women, girls, and also grandparents too. And I was really interested. I was really happy when Lucy came up with that question about men. It's really difficult to involve them. It can be challenging, right? But and I'm glad the way Regina answered it. Try to start somewhere before you get to where you want to be. So I think that's a good strategy. So yes, so that's what I'm gonna look into. But I will talk more about it as we go on. Okay.
Thank you. Beautiful introduction. Thank you so much. So everyone, that brings us to the final part of today's session, which is basically me giving some quick NETFA announcements. So I'm going to share my screen. Here we go. So just to wrap up, we thought we would let the network know about a couple of things that we've been up to. So on the 8th of April, we actually launched the inaugural NETFA National Leadership Program. So we have 12 women, including Kathy as well as a support person. So these 12 women are people from communities affected by FGMC, from a wide variety of states and territories across Australia. So we've got people from the Northern Territory, from the ACT, South Australia, Queensland, New South Wales, and Victoria. Apologies if I've missed any of those. And the women come from a variety of cultural backgrounds. So there are people from African, Middle Eastern, and Asian diasporas. And the women also come from a variety of professional and lived expertise. So some people are either currently studying in the health fields or have quite a few years of experience working with diverse communities on health promotion and community engagement. So it's a really beautiful, diverse, and brilliant group of women. And you are all invited to the graduation event, which will take place at the end of October this year. What we'll be covering over the 7-month program is, I think about it as 3 distinct groups of skills. So the first one is in-depth knowledge on FGMC. So from various angles, whether that's sexual reproductive health lens or human rights lens and gender inequality lens, etc. And then the second group of skills is about building up the women's confidence and leadership skills, as well as their structural frameworks. So that's things like talking about intersectionality, talking about culture in a critical way. And then the third group of skills is on strategic storytelling. So we've partnered with organizations like Democracy in Color, whose core business is on, campaign strategy. So we'll be asking these women to think about what is the big picture impact that you want to have? And then therefore, what are the stories that you want to tell about FGMC? What sort of content do you want to be making? So we'll also be taking people through podcast producing training, video production training, and then towards the end of that, the plan is at the graduation event, we'll be able to share some of the podcasts and video resources that these women will produce. So that's briefly about the NETFA Leadership Program. The second thing I wanted to ask of all of you to think about is we are preparing a term of reference for all of you, especially if you work in organizations, to become official NETFA partners. So please let us know if you are open to that. I'll be sending out some more information so that, you can become a part of the NETFA network officially. And then finally, please expect an email from me, if not today, on Friday. I'll be asking you what you think will be useful for the next NETFA Online Peer Exchange. At the moment, we're scheduling it in 6 months' time. So roughly, towards the end of this year. I'd love to hear from all of you so that we can, as you've seen at the start of this session, we really do tailor it to what you want these sessions to be. So please tell us what you want. And finally, please stay in touch with us. We're on Twitter, we're on Insta. Also, our website is netfa.com.au, and also follow us on LinkedIn and Facebook as well. Thanks, everyone. That brings our event today to a close. Thank you so much again for your beautiful contributions. Unless there's any burning questions, this is, yeah, have a lovely Wednesday night or afternoon. Thanks everyone.
Thanks
Thank
everyone.
you.
Bye.
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 Rani, just wanted to say thank you. This has been wonderful, and you organised it so beautifully and facilitated it so beautifully today.
Oh,
we
thank you.
And are very grateful. So thank you.
Thank you. I'm so glad people from WA could come. It makes me so happy.
Thanks,
Felicia.
thank you. It's great to learn from you all. Thanks.
Thank you. Thanks, Patricia, for joining, even though you're working. Really appreciate it.
Thank you.
Bye, Kathy.
See you later.
I'm going to stay on.
Oh, okay. What was that expression? But sure.
Rani, you might want to stop the recording if it's.
Oh yeah, for our silly parts.